of introducing Dr. Lee Kaplan. And Dr. Kaplan is going to talk about the nature of body weight, what the clinician must know. And this is a real treat to have Dr. Kaplan giving our first lecture. It always is. He has dedicated his career to studying obesity, and both in the lab and, most relevant to all of us in medicine, to educating about the pathophysiology of obesity, and he does it so well. He currently he's a professor at the Geisel School of Medicine at Dartmouth, and runs the weight center there. But before that, he was 4 years at Harvard Medical School. He's the founding director of the Mass General Hospital Weight Center. Founded it a long time ago when there were few weight centers across the country. He also is really one of the founders of the entire field of obesity medicine. I know he's blushing now, but it's true. And for years, he directed, along with several of us, the Blackburn course in obesity medicine at Harvard. And so for years, he's been educating on mainly the pathophysiology of obesity. And so I'm so excited to hear him. Every year I hear his lecture, and it doesn't matter, even if I can listen to him talking about Raging Bull and Robert De Niro over and over again, and there's always something new that I learn about obesity. So Dr. Kaplan, welcome.
Thank you, and thank you for the the reason that I could be a founder in this thing is just that I'm very old. So when you're very old, what happens is you collect things that you've been working on. I hope everybody can hear me. Caroline, can you hear me? Well, we'll hear if I'll get feedback. If not, I'm going to talk about the nature of body weight, the nature of obesity in particular, and I'm going to try to make the case that obesity is a disease. And you say, well, why? We all believe obesity is a disease, but we don't often act like we believe it's a disease. And more importantly, we frequently have trouble convincing the rest of the world that obesity is a true disease in the same way that diabetes is, or heart disease, or cancer, or the like. So let's get started. These are my disclosures. I work with a number of companies in all aspects of obesity. None of them has a bearing on today's lecture. My objectives today are first to describe the ubiquitous impact of obesity on patients, on society, and on the healthcare system. We'll come back to that. I will describe the importance of the disease model of obesity, both from a clinical, and actually more from a clinical than a biological perspective, although I will touch on the biology briefly. I'll describe the clinical impact of recent developments in obesity care, meaning all of the new medications, bariatric surgery, and the like. And I will describe what I hope will be a very short presentation on the unmet needs in obesity care. So what is obesity? Well, the World Health Organization says it's a disease characterized by abnormal or excessive fat accumulation that presents a risk to health. But I'm not really sure that that's precisely accurate, because there are a number of diseases that are associated with abnormal fat without being obesity. But of course, excessive fat accumulation is part of the spectrum of characteristics of obesity. A widely accepted description, however, is that it's a complex, chronic, and possibly progressive disease. We say it's progressive, but we don't have a way of measuring progression. In diabetes, we can say, well, you have progression by the progression of beta cell dysfunction. And you can separate that out from how high the triglycerides are, or how high the glucose is, or hemoglobin A1C. And so you can differentiate between progression of the disease, again, by measuring beta cell function, versus how well we control the disease by measuring something like hemoglobin A1C. In obesity, we can't do that. We can't really separate progression from poor control. And so we say it's a progressive disease because people do get bigger and bigger. But is that because the disease is progressing, or simply because we haven't been able to bring it under adequate control historically? Why is it a disease? It's a disease because it results from abnormal metabolic regulation of body fat mass. The body does not regulate correctly. We'll come back to that in a minute. It causes pathology and it diminishes health all by itself with no complications. But it also is a major risk factor for more than 200 other diseases. So therefore, it does cause complications. But in its own right, with no complications, just having excess fat or abnormally placed fat, it is a disease in its own right. So whatever the external causes or contributors, and there's some genetic, you're going to hear about that. There are some that are mostly environment. The epidemic is from changes in the environment, not changes in our genetics. But the final common pathway is inside the patient who has obesity, and it reflects the disruption of their physiology. And that disrupted physiology then leads to accumulation of excess amounts of fat and putting fat in the wrong places. And then that leads to all of the many complications that we'll talk about. Well, as I mentioned, the adverse effects of obesity are ubiquitous. I've already mentioned that it's associated with more than 200 clinical complications, including metabolic diseases, inflammatory diseases, degenerative, mechanical, psychological, and of course, as you've already heard Marie talk about, cancers. At least 18 cancers are associated with obesity, including all of the reproductive cancers, most of the GI cancers, and a variety of hematological cancers as well. But that's only the beginning of how obesity adversely affects the human body and adversely affects society when it's as prevalent as it is today. It also leads to social exclusion with psychological injury, social disparities, alienation, and that creates a vicious cycle, which puts a downward pressure on social function of people with obesity. And when obesity is as prevalent as it is in the United States today, 75% or more of people have the disease of obesity. And you say, well, that's not a number I've heard before. I heard it was 42. 42 is a BMI over 30. But people who are overweight, well, I don't like the term overweight because it's purely anthropometric. It's not medical. But people who have a BMI between 25 and 30, who have been classified as overweight, they don't have a different disease. They just have a very mild form. Prediabetes is not different from diabetes. It's just much more mild. And so obesity, the disease, even in the mildest forms, affects more than 75% of our population. So when you affect that number of people and you have downward pressure on social function, you can have a disruption of social function across society just from obesity, in addition to all of the other things that may lead to that. But beyond clinical complications and social exclusion, there's also a downward pressure on economic function. People who come and who grew up in the same zip code have less of an education if they have obesity. And for the same education, they get less of a job. And for the same job, they get paid less. And they have less opportunity for career advancement. Once again, a downward pressure, a consistent, persistent downward pressure on economic viability and function if you have obesity compared to not having obesity. And if you then apply that to the entire society, that puts a downward economic pressure on society with increased medical costs, increased indirect costs, decreased productivity, and therefore less economic success. But the one that I want to finish on for this slide is really something that we don't talk enough about. And that is the clinical interference. Obesity does cause or contribute to all these more than 200 diseases that I showed at the top of this slide. But even for diseases where obesity has no role in causing or exacerbating the disease, it interferes with our ability to screen for diseases, diagnose diseases, treat diseases, and follow up on the care of those diseases. These are for diseases that have nothing to do with obesity because changes in body shape, in pharmacokinetics, pharmacology, because of obesity, can interfere with screening tests, can interfere with the sensitivity of diagnostic tests, whether they be radiological or imaging tests, or they be biochemical tests. They interfere with the ability to do certain kinds of surgical and endoscopic procedures. They interfere with the effectiveness of medications, and they interfere with follow-up. So basically, obesity touches every aspect of medical care on an individual basis, on a professional basis, all of us who care for patients, and on a social or societal basis. Well, so how have we been doing? Each decade, the United States Department of Health and Human Services runs a program called Healthy People. We're now in the middle of Healthy People 2030. Healthy People 2030 was started around 2020, and basically we set a series of goals. We have goals for diabetes, we have goals for heart disease, cancer, a variety of other diseases. And since Healthy People 2000, we've had goals for obesity. So how have we done with those goals? Well, in around 1990, 1988, when Healthy People 2000 started, the prevalence of obesity in the United States was 17%. The goal was that we would bring it down by 23%, down to about 13%. But during that decade, the rate actually went up to 34%, up to about 23%. Okay, so we didn't do very well. So we got more aggressive in the next decade, and so we started at about 23%, and we set even more aggressive goals to reduce the rate of obesity, but largely by changing eating behaviors and exercise behaviors, and we aimed to really try to make up for lost ground by decreasing the rates of obesity by 33%. But in that decade, ending in 2010, the rate of obesity actually went up 51%. And by then, we were up at 34% rates of obesity. And so in the next decade, we said, well, we're not obviously doing very well. A lot more focus was put on eating behaviors and exercise behaviors. And actually, in the next decade, ending in 2020, what we found was that eating and exercise behaviors had improved. As a society, we were exercising a lot more. We were eating less concentrated sweets. We were eating less processed carbohydrates, and we were eating less saturated fats. And yet the rate of obesity continued to go up. We only had modest goals, but at this point, we had learned our lesson. And in the current decade where we are today, we are still seeing an increase, and it's estimated that between 2020 and 2030, we're only halfway through it now, the rates of obesity will have gone up 25% based on the fact that they've already gone up more than 12% since 2020. So what we're seeing then is a continued rise in the rates of obesity. There have been a few reports in the last couple of months that maybe that has stopped, but we get those reports all the time, and then the next year they disappear. So these are much longer reviews, and they show that obesity is slowing. The rates of increase are slowing, but we're also running out of people. I mean, there are genetic resistance to obesity in about 15% of the population. So the maximum we're ever going to see probably is 85%, even if we don't do anything about obesity, because the other 15% are resistant. We're already at 75%. Okay. So what is obesity then? Obesity is, I've already talked about the definition clinically, but it's important as we think about obesity and we try to communicate with our colleagues that obesity is something serious that we have to take seriously for its own sake and not just because it causes diabetes or heart disease. But we have to separate it from the cultural desire for thinness, because lots of people would rather be thinner, but they don't have the disease of obesity. They perhaps have a normal weight, normal fat distribution, but they would like to be thinner. That is not obesity. And we should not confuse even the use of modern medications for getting people to be thinner from treating obesity. Now, of course, many people have obesity and they live in our society, so they have the cultural desire for thinness. When you have both, obesity basically trumps the other because the cultural desire for thinness can be a motivating factor to get the obesity taken care of, to follow the recommendations for care, to change lifestyle in a healthy way. But I want to emphasize that as we talk about the disease of obesity, we're talking about the disease of obesity and not merely the cultural desire for thinness. And understanding that difference is key to the optimal use of any anti-obesity therapy, whether it be lifestyle or medications, or surgery. We'll come back to that. So the fundamental question, if we're asking the question of is obesity a disease, is where is it best treated? Is it best treated within the healthcare system, which would be typical of a disease? Or is it best treated in a strip mall or a commercial environment where it started being treated in 1957 when Weight Watchers was founded? Obviously, there are other approaches in the commercial environment, and sometimes the commercial environment overlaps substantially with the healthcare environment. But is this fundamentally a problem that needs to be addressed in the healthcare environment, or should we simply send it off to the commercial environment without getting involved ourselves? Well, what's the purpose of healthcare? The purpose of healthcare, in the broadest terms, is to relieve suffering that arises from disturbances in the human body, whether they be physical disturbances or physiological or pathophysiological disturbances. And that suffering, and it doesn't matter whether the disease kills you or it doesn't kill you, whether it has a minor effect or a major effect. If it causes suffering, we typically go to the healthcare system to relieve that suffering. And that suffering comes from symptoms, from having a headache or having difficulty seeing or having nausea or whatever it is that the symptoms, you want to get rid of those symptoms. It comes from disability because you want to obviously be capable of interacting and doing the activities of normal life, interacting with the world appropriately. And it comes from fear of complications, of dying early, of developing a disability in the future, of not being able to participate. Well, obesity actually causes suffering in every one of these ways, and I'm going to explain a couple of them in a minute. And so relief of suffering from obesity-induced symptoms, disability, and fear falls squarely within the responsibilities of normal healthcare. And we can say that to anybody, no matter what their sophistication about pathophysiology is. I can spend a whole hour talking about the pathophysiology of obesity. But we can talk about these aspects of why it's a disease to anyone with a great deal or no deal of medical sophistication. Everybody understands why they go see a doctor or other healthcare professional, and obesity really meets those criteria. Well, what are those symptoms of obesity? Well, obesity causes symptoms in ways that other metabolic diseases, such as early stage diabetes, early stage kidney failure, early stage or kidney disease, early stage liver disease, hypertension, hypercholesterolemia, none of those things cause diseases, particularly in the early phases, but obesity does. It causes appetite-related symptoms, excessive hunger in some patients, inability to achieve satiety after a meal in other patients, preoccupation with food and meal planning, often called food noise. That's the one that's most common and the one that we talk about the most because the newer treatments, including surgery and medications, have a dramatic effect to decrease food noise even before you lose weight. And patients love that. If you don't believe me, go see the Golo ads on TV or the Noom ads or the Row ads. They all talk about the decrease in food noise and how that saves space or makes space in the human brain for people to do other things that they want to focus on and not be distracted by food and planning the next meal. These symptoms do respond to treatment quickly. But there are other symptoms of obesity without complications of the obesity. If you can't walk up a flight of stairs without getting short of breath, but you have no heart disease and you have no lung disease, you have obesity-associated dyspnea. That is from obesity. And difficulty or inability to perform normal activities of daily living because you can't reach certain places or you can't put your clothes on or you can't stay clean under certain circumstances without excess weight or a shower. Discoordination from altered body shape or center of gravity, leading to potentially to increased risk, but just the inability to get up from sitting on the floor or to interact with your children or grandchildren. And control of these symptoms requires weight loss, but these are symptoms that can improve with effective therapy. And then finally, I want to talk about the dysphoric symptoms that lead to social and psychological disruption. These are symptoms that aren't caused by the obesity. They're more caused by society's response to having obesity because obesity is a public disease. And more than half of our patients are going to describe having either been bullied in the extreme or having been made to feel embarrassed about eating in public or made to feel embarrassed about being in public or made to feel bad because they have obesity. But again, that's not from a complication of obesity. That's from obesity itself and the way society treats people with obesity. So the goals of obesity treatment then, if you think about it in this medical context, are one, weight loss, because weight loss has tremendous beneficial effects, as many of the other speakers in this course are going to describe. But beyond that, improvement in obesity symptoms. People want that food noise to go away. They want that excess of hunger and craving to go away. And the physical symptoms, of course, they want them to get better, and the dysphoric symptoms as well. Improvement in existing obesity complications is a third goal of treatment. And the fourth goal of treatment is to prevent future obesity complications, if for no other reason, to decrease the fear associated with having obesity and all those fears that I described earlier. Well, body fat mass is physiologically regulated, and I would be remiss if I didn't at least mention in a couple of slides the nature of that regulation and why that regulation is disrupted in obesity, whether it be from the biological causes of obesity or the environmental causes. At multiple stages during the normal life cycle, including loss of baby fat, fat changes with puberty, going up a little bit in girls, going down a little bit in boys during puberty, fat changes during and after pregnancy and lactation, fat changes with aging and menopause in women, those changes occur without voluntary interaction by our own behaviors. People lose baby fat, babies lose baby fat, and never grow fat back in those areas like the upper legs and the like in the vast majority of people without putting them on a diet. We don't put babies on a diet to get rid of the baby fat. We don't put girls on a diet to get rid of the normal fat accumulation during puberty. We don't typically put people on a diet at the end of pregnancy and lactation. These things happen because the body regulates them. Not only does this happen without active, purposeful intervention, but these changes in body fat are in different parts of the body. Fat associated with pregnancy is in a completely different part of the body from fat associated with baby fat and even fat associated with menopause fat. Now, there can be overlap, but the point is that this is all a regulated process. At any given time, though, during adulthood, during childhood, what have you, the amount of fat mass and the distribution of fat mass is defended. It's defended by a process called metabolic adaptation, and that metabolic adaptation will prevent you from overfeeding a child and making a skinny child and making them as heavy as you want them to be. And it also prevents the effectiveness of simple calorie reduction as a way of treating obesity. Fat regain after resolution of acute illness or injury is one of the purposes of defending the fat mass. We all lose weight when we have the flu or we have COVID or we get sick in other ways, and we gain it back because the body needs to maintain its fat stores because its fat stores are its energy stores. Fat loss in response to acute overeating, we always complain about the excess food that we take in around Christmas and New Year's, but we lose it automatically because our body, if we are at where our body wants to be beforehand. And of course, fat regain in response to calorie restriction is the same process. So obesity occurs when this regulatory system seeks and defends an inappropriately high fat mass. You can't take a skinny person who's naturally skinny and make them permanently overweight or have obesity. You can do it in the movies. They do it. People can overfeed themselves. Robert De Niro, Caroline mentioned Robert De Niro, gained 40 pounds filming Raging Bull, but he was eating 6,000 calories a day to gain the weight. He was eating 4,000 calories a day to maintain the weight. And as soon as he stopped filming, without trying at all, he was within 5 pounds of his baseline weight 6 weeks after he stopped filming, even having lost 35 of those 40 pounds. So it happens automatically, and it happens in both directions automatically. It is only easier to gain weight than lose weight because we typically are on a diet all the time. 40% of the American adult population is on a diet at any given moment, 90% at some point in their life. So we're always trying to push ourselves below where our body wants to be. And if you're below where your body wants to be, it's going to be easy to gain weight. For Robert De Niro, it was easier to lose weight. For Renee Zellweger, it was easier to lose weight because she was purposely trying to put herself above. He was trying to purposely put himself above where his body wanted to be. Well, so the environmental influences, some of which are listed here, the ones listed here on this slide are the ones that we have some degree of control over. are constantly pushing up our defended fat mass, are changing the physiology, are disrupting the physiology so that the body wants to have more fat than is healthy, than is necessary. And so our goal has to be not to try to push against these things, but to actually try to reverse them so that we can get to a position where the body feels comfortable, wants to be at a lower fat mass and a better distribution of that fat. Well, the body vigorously defends its desired fat mass through a protective mechanism that I've already said is called metabolic adaptation. That metabolic adaptation includes increased appetite and decreased energy expenditure, and the decreased energy expenditure is through decrease in thermogenesis, not decrease in physical activity. There's all of these symptoms that I talked about earlier. The appetitive symptoms are the manifestations of this metabolic adaptation. It's mediated by changes in a number of neuronal activities, but also hormones, including the ones listed here. And we'll talk about a few more in a minute. And it leads to regain of the lost weight, or it leads to loss of the gained weight if you're purposely trying to gain weight, as the movie stars have done. So what this implies altogether is that overeating isn't what causes obesity. Overeating will be dealt with by a normal regulatory system. Obesity causes overeating. So if you have the disease of obesity, if something has given you the disease of obesity, whether it be a hypothalamic injury or your genetics or the environment that I've just talked about or a drug, that obesity will cause you to overeat because the body now wants to have more fat than is healthy. And therefore, undereating doesn't fix obesity. Fixing obesity leads to undereating, which is why the newer medications are so effective, because they help to fix obesity. And then the body responds by eating less, burning more, and pushing itself down to a lower weight. These conclusions have critical implications for how we control obesity in the long term, because if all we want to do is fight metabolic adaptation, we have about a 5% success rate. But if we want to use the normal regulatory pathway and try to bring people back to normal, as we do for almost every other disease, think hypertension, think diabetes, think heart disease, think cancer. If we want to bring the body back toward normal, we can do it and maintain it over a long period of time. And the data with new medications, with bariatric surgery, demonstrate that. So effective anti-obesity therapies are going to push down the defended fat mass. They're not going to just simply try to say we're going to force our way below where the body wants to live. Well, let's look at how we've been doing. If you look at the last 60 or 65 years of treatment of obesity, you can see that metabolic and bariatric surgery in the line at the top has been about stable, about up to 30% weight loss. That line goes from red to green because bariatric surgery, when it was first introduced in the 1950s and 60s, was incredibly unsafe, with death rates as high as 5 to 10%. Today, those death rates are the same as the death rates associated with taking your gallbladder out, about 0.1%. And that came from the introduction of laparoscopic approaches, better training, more experience, and better standards for bariatric care. So the effectiveness is the same, but the safety is much better. At the other extreme, if you look at the yellow bar at the bottom, the effectiveness of intensive lifestyle therapy between 4 and 5% over a 5 to 10 year period have also been stable. But these approaches have improved over the last 60 years because our ability to deliver appropriate lifestyle therapy and our ability to get patients to understand what appropriate lifestyle therapy is has improved and has been made easier. Where we've really had trouble is with medications, because medications for the first 40 of the last 60 years have been no better than lifestyle. Yes, they add together. It's not fully additive, but each one can help the other one. But only in the last 15 years, in what I call generation 2 drugs, with combinations of phentermine and topiramate, with Contrave, which is a combination of bupropion and naltrexone, or with liraglutide, have we seen that medications reliably do better, modestly better than lifestyle. And over the last 4 years, in what I call generation 3, with the introduction of semaglutide at higher doses and tirzepatide, we can see that the effectiveness of pharmacotherapy for obesity is dramatically better than it used to be. And if we look down the line to the future over the next 5 years, we can anticipate with drugs that are already in late-stage clinical development that we will be able to equal or better the average efficacy of bariatric surgery with medications. Well, of course, there's all kinds of discussion about medications that have to be, this is a chronic disease, they need long-term use, et cetera, et cetera. I'll leave that for other discussions in this course. Suffice it to say, though, our ability to treat obesity medically has dramatically changed in the last 4 years and is going to continue to improve over the next several. But even though people with obesity can be treated effectively, there are all kinds of challenges given the size of the problem and the cost of the problem. And we'll get back to those in just a second. Obesity is not just excess fat, though, because that excess fat leads to metabolic stress. There's an interaction between obesity and metabolic stress, leading to ectopic fat accumulation in virtually every organ in the body, systemic inflammation and local inflammation in various organs, cell injury in those organs, and fibrosis, whether it be the vascular system, the heart, the liver, the pancreas, the kidney, skeletal muscle, or elsewhere. In all of these ways, obesity then jumps from a disease of fat to a disease across the entire body because of its many complications. Well, what's the progress been in our management of obesity-related diseases? This is a quick slide to give you a sense. We used to talk about comorbidities. Obesity was associated with these 200 diseases, and we call them, therefore, comorbidities. We didn't know anything about causation. But in recent years, probably over the last 10 to 15 years, we've learned a lot more about causation, and we recognize that many of these diseases are actually caused or contributed to by obesity. And that relationship, that causative relationship, can allow us to define many of these 200 comorbidities as complication. But we've done even more over the last few years, where we've been able to demonstrate that if you treat the obesity is really underlying these other diseases, because when you treat the obesity, you can improve or bring into remission these other diseases. And I call those addressable obesity complications or obesity treatment targets. And if we look at what we've learned, even over the last few years, what we can say is that all of the diseases on this slide, diabetes, atherosclerotic cardiovascular disease, heart failure, kidney disease, liver disease, sleep apnea, on, all the way down in recent months, alcohol use disorder and opiate addiction, can all be improved or brought into remission, depending upon the disease, by treating the underlying obesity. And the thing I want to emphasize in this slide is not the length of the list. I want to emphasize how new these data are. We knew about bariatric surgery and diabetes. There were good data back in 2007. But for all these other diseases, good data, published usually in the best journals, Lancet, New England Journal of Medicine, Nature Medicine, and the like, have all been published since 2021, including several published in 2024 and 2025. So the ability to say that treating obesity treats all these other diseases is a brand new concept that's only been in the medical literature for a short period of time. And of course, with these new medications and newer ones to come, the list is growing very rapidly. The most recent ones on addiction and on alcohol use disorder have really been published. Good studies have been published only in the last couple of months. But what do we need in the next generation of new anti-obesity medications? We need new average improved efficacy, but we're running out of headroom. If the medications cause an average of 30% weight loss, we don't need better averages. We need the distribution to be better. We need people who don't do well with these medications, who don't tolerate them, to have alternatives like we do for other diseases. So we need those complementary mechanisms of action, and they're being developed. We need improved ease of use for patients. This escalation process and the complication and the injections, et cetera, we need to have better medications. We need improved ease of use for prescribers. The escalation process and the intolerances, GI intolerances, and many of the medications can interfere with our ability to use them. And of course, we need preservation of lean mass, muscle, and bone, and medications that target the underlying pathogenesis of obesity, which we don't even know what that is yet. So there's a lot of work still to be done, even though we've made so much progress. But in comparison to the number of patients in need of care, we have to consider that adequate care of obesity is a scarce commodity. We have too few providers who know their way around this area. We have an inadequate supply of therapies that's only just beginning to be addressed now. We have inadequate financial resources to overcome the high costs and the inefficiency of the current care model. So equitable access to this scarce commodity requires a new model of care with retraining. That's in courses like this one. Patient prioritization by clinical need. We can't treat 120 million people tomorrow morning. We can't afford it, and we don't have the wherewithal to do it. We need a more efficient care model, but we do need prioritization of who needs and will benefit most from therapy early. And then as therapy gets less expensive and as we have the resources to do it, we'll start to broaden that therapy. So given the size of the problem, if we're successful, we get a lot of benefits. I'm not going to go through this whole slide, except to say we should see a reduction in the severity of obesity. We're not going to see a reduction in the rate. You don't see a reduction in the rate of diabetes by treating diabetes. You see a reduction in the rate of diabetes by preventing diabetes. So we won't see a reduction in the rate of obesity, but we will see a reduction first in the severity. We'll see an improvement in complications. We'll see advances in mental health and quality of life, a reversal of the recent trend toward a lowered life expectancy, a decrease in healthcare costs ultimately as we save money. We might even see an improvement in economic productivity, and we might even see food industry incentives go from quantity to quality as we move forward and understand this better. And the best benefit we're going to see is going to be in the population with the highest current rates of obesity who get the lowest access to care today, providing that we can improve that access to care. So I want to just end by saying, if we want to treat obesity more effectively, we have to fully understand why it's a disease in its own right by itself, and how that disease differs from the cultural desire for thinness. We have to understand what being a disease means for effective care of obesity, where the care should be delivered, who should deliver it, how it should be delivered, and how we need to come up with better and more efficient models for that delivery. We have to understand what the barriers to effective care are and the diverse forces, some of which are malignant forces, other are benign forces, working against such effective care. And most of all, we have to focus on the patient, because the patients are the ones who benefit the most, and they benefit in all the ways that cause them to seek care in the first place. So I'll end by saying, Charles Eisenstein, the author, wrote, "The world as we know it is built on a story. To be a change agent is first to disrupt the existing story of the world, and second, and critically, to tell a new story so that people have somewhere to go. You can't just say the old story stinks, you got to have a new one that's better." So what is the current story of obesity? What is your view of the current story of obesity and its contribution to metabolic disease, cardiometabolic disease, and all of the other complications that I talked about? And how does that need to change? And what is our role and your role and the audience in promoting that change? Thanks very much for taking time to listen.
Thank you so much, Dr. Kaplan. That was incredibly thought-provoking, which was the intention for this fundamental talk. Now we understand obesity is an upstream disease. Thank you so much for doing this for us today and kicking us off.
My pleasure.